My name is Chad Donnelly. I'm a spine surgeon in my hometown of Dallas, Texas. And today what I want to talk to you about is neck fusions or cervical fusions, the surgery, and really what the recovery is and what to expect from recovery. So in this video, I'm going to go over the most common type of neck surgeries we do. I'm going to tell you about the anatomy and in general, what the recovery is from those types of surgeries. So let's start with some basic anatomy. When I talk about cervical fusion or cervical surgery, really what I'm talking about is the neck. When I talk about the neck, it goes from the skull. Then you have cervical 1, cervical 2, cervical 3, cervical 4, 5, 6, and 7. And then it goes into the thoracic spine, so the T-spine, and then the lumbar spine, lumbar spine. For the purpose of this video, we're talking about the cervical spine, so the bones in the neck. The majority of spine surgeries are done in the neck are done from cervical 3 to cervical 7. That's where the most arthritis develops. That's where the most type of surgeries are. And in terms of the surgeries that we're talking about here, a fusion surgery. Essentially, that's mending those two bones together. So going between the two bones at the disc space, cleaning out the disc space that has the arthritis, that has the pinched nerves, that has the pinched spinal cord, and then going from there in terms of stabilizing the spine. So why do we even do a neck fusion? Well, the whole goal of doing a fusion in the cervical spine is really to relieve the pressure that are on the nerves or on the spinal cord. I like to think about it as a tree trunk and tree branches, where the tree trunk is the neck, is the spinal cord, the tree branches are the roots that come off of it. When these get squeezed, that's what causes pain. That's what causes spinal cord compression. When the nerves get squeezed, that's what causes arm pain or numbness and tingling down the arms, down the legs. So look, there's different types of surgeries. You can go through the front, and that's when you hear about an A for ACDF, A for anterior. Anterior is going through the front, or it could be from the back of the neck, posterior, meaning the back part of the neck. And the surgery we're talking about here is something called a PCDF. These other levels, C stands for cervical, D for decompression, F for fusion. So it's an anterior cervical decompression and fusion, or a posterior cervical decompression and fusion. Another pretty common question is, so once we go through the front of the neck and we remove the disc space, what do we, the surgeons, put in there? And usually we put in these cages. These are 3 different titanium cages that I'm holding up here, all with a little bit of a different type of technology, different type of footprint. But essentially, once we clean out that degenerative disc space, something's got to go there. And so back in the day, we used to harvest bone from your hip and put in hip bone there, and that's fine. There's some pros to that, many cons, negatives to that. Nowadays, we have the fancy technology to pretty much print these 3D printed, mesh shaped. These are kind of almost spray painted with a type of bone that, a type of metal that helps stimulate bone growth. So you have some really fancy products, different fancy things that help stimulate bone growth, help mend those bones together. But at each of those levels, so if it's a 1 level, a cage goes in there to keep the height up and to prevent any additional arthritis from occurring at that level. So the next question I get asked is, okay, so once you have the cage in there, what's the rods or screws? Well, there's no rods and screws when we go through the front. Instead, there's a plate, so it's a pretty thin plate that lays over the front part of the bone. And then there are screws that go through this plate to, you can think of it as hold the cage in place or to provide extra stability at that level. Now we do have, and that's not pictured here necessarily, some fancy cages where just through that cage itself, you have a screw that goes through it. And sometimes if you do that, you don't use the plate. Pros and cons to either way of that. This is a giant plate. This is for a 4-level ACDF. We don't do too many of those, fortunately, but that's where you see about the plates and then little screws that go through the front, pretty small things. Again, when we or I or hopefully most surgeons go through the front, it's not too terribly long of an incision. I would say it's, if you think about the small size of a credit card, probably half the size of that. So this is an actual patient of mine. This is at a 3-level neck fusion through that incision there. And then sometimes if it's a 2 or a 3-level neck fusion, many spine surgeons will leave a drain back there. Definitely not wrong to not leave a drain. I don't know if controversial is maybe an overstatement there, but some people don't leave drains. Many do. The surgeon's not right or wrong to leave one or not leave one, but that's the drain that comes out. And then almost always that's pulled overnight. The stitches I use, and probably I would hope most of my colleagues use, are absorbable stitches. It heals really well, but that's essentially the issue. We go in through the front, clean out the disc, leave in a spacer, and by going in through the front and leaving that spacer, we're taking the pressure off of that nerve. Okay, so let's talk about the next surgery. This is a PCDF. Again, the CDF is cervical decompression and fusion. P for posterior, so the back part of the neck. Now, this one is a bigger incision. This one's it could really vary just based on the number of levels and patient anatomy, but it might be as long as a writing utensil, a pin, if you will. It's not a tiny incision, big incision when you go through the back part of the neck. You have to do some muscle sparing, muscle splitting approach to expose all that area. And it's really the workhorse of cervical spine surgery. Again, the majority of patients won't get one of these. The times when you need these is a whole different discussion, not totally germane from now, but it's a more powerful surgery. You can get a lot of work done, certain pros and cons to going from the back compared to just doing it from the front. And again, going to a common question I get asked all the time, are there rods and screws? Well, again, when we talk about rods and screws, generally spine surgeons or patients on the internet, we're talking about the lumbar spine. That's where you have bigger rods and screws. But yes, in a PCDF, there are rods and screws. Now, these are smaller, thinner screws, smaller screws, but I'm sure if you're the patient, you're like, well, there's still rods and screws. But yes, that's what gives you the stability, holds the bone still while the bone graft mends and fuses those bones together, because extraordinarily likely the surgeon has also done a decompression surgery where they used a tool to take the pressure off the spinal cord. That'd be one of the biggest indications with this type of surgery is multiple levels of spinal cord compression. All right, so let's get to some more specifics about the recovery. Now look, before I go on a recorded platform, I just want to say the obvious things. Look, recovery varies person to person. There's many factors. It's like taking your car to the shop. Factors of age, the overall health of you, being the machine, the vehicle, what's getting fixed. Is it just the transmission? Is it just the brakes? How many levels are getting fused in this analogy I'm continuing to go with? There's also a genetic predisposition, your genetic predisposition to pain, to recovery, to wound healing. So there's a lot of factors that are very different from you versus your neighbor versus your coworker in terms of their experience from maybe a similar surgery. There's also, I'm not giving you the gospel here. Every surgeon has a different protocol, different experience. Some of it's backed to the literature, some of it's backed by their last complication or their last patient. But from my standpoint, you need to follow your surgeon's plan. So don't be going out there and telling people this is what you saw online, and so that's the recovery you want to do. This recovery isn't just for you. This is kind of a general recovery. In fact, even if you're one of my patients, this might not be your specific recovery. Again, it varies from person to person. But in general, some high-level cervical fusion timelines. Look, the full fusion, if you were to get a CT scan to see if the bones bended together, that could take 9 months, 12 months, up to 2 years in certain cases for the bones to totally solidify. But most day-to-day functions, much more functionality, returns much sooner. For many, many people, or my patients, when it's a few levels you're fixing, basic activities, you're back to that 4 to 6 weeks later, doing great. So let's get into some of the expectations, the immediate post-op stay. Patients, interesting, always ask me, look, is this a sedation? Am I in the twilight? Am I really going to sleep? And yes, this is a full sedation surgery. You're intubated, you're sedated. I have an MD, or I have an anesthesiologist, a doctor of anesthesia, taking care of you for all my cases. CRNAs are great. Not trying to say anything bad about them, but different hospitals have different requirements. From a drain standpoint, that's what I talked about earlier in terms of having a drain come out to take off any extra blood or something like that that might accumulate. For most patients, if they have a neck fusion from the front, you just have that one overnight if you had one at all. From the back of the neck surgery, maybe you have that for 2 to 3 days. From a brace, and I'll get into that here just in a little bit, yes, usually have a C-collar after the surgery. Another thing to talk about is post-op physical therapy. So yes, in the hospital, we do start formal physical therapy, up walking around with a physical therapist, and your hospital stay varies based on many of those factors you talked about before. Look, for most people, if it's a 1-level ACDF, you might go home that very day. Totally safe surgery to send people home that day. If it's a 2-level, 3-level fusion from the neck, maybe you stay overnight. If it's a posterior cervical decompression and fusion, again, this varies. Maybe you stay for 2 nights, maybe you stay for 3 nights. Again, it just varies, but that's a general hospital stay expectation after cervical fusion surgery. After surgery, there's certain medication protocols that we go through, and there's certain expectations you should have. One of them is you should expect to have some throat pain, especially if you get intubated, and then pulling the esophagus aside definitely causes throat pain, definitely causes some difficulty swallowing certain foods. It's also not unusual to have neck pain. I mean, that makes sense. We're stretching the neck out. We're cutting through neck muscle tissue if we're going from the back part. And we're also usually taping your shoulder down or putting you in some type of retraction or traction device so that we can see the spine better. So you're just uncomfortable. You're sore. It's just not an enjoyable position to be in for a couple hours. From a discharge medication, again, this varies surgeon to surgeon, but usually a surgeon's going to discharge you on a narcotic, a muscle relaxer. I usually encourage my patients to get a stool softener, and then maybe they also discharge you some oral steroids to kind of help with the inflammation after surgery. So what I want to do at this point is go over a week-by-week recovery. Again, this varies based on your pain levels, your surgical levels, your functionality going into that surgery, whether we went from the front, whether we went from the back. Again, this varies patient to patient, but in general, I'm going to give some high-level views of what to expect. So for those first couple weeks, week 0 to week 6, let's call it, most surgeons don't want their patient to lift more than 15 pounds, 15 pounds, nothing more than that, because we really want the tissue to heal, the bones to start mending, and not to pull any of the tissues apart, especially in the back part of the neck. We use the term BLTs, bending, lifting, and twisting, and we really want the patient to limit their bending, lifting, and twisting during that time period. It's very likely the patient will be using a neck brace during that entire time. There's also a big emphasis on nutrition, which I'll get to in a little bit, but I want the patient trying to get a good healthy diet. Carb loading the night before surgery, a little different argument there, but then going forward, making sure they have a good healthy diet. Obviously, of trying to avoid as many harmful toxins that you can during that time period. This would obviously include tobacco, cigarettes, things like that. I let my patients, the day they get home, shower, take the bandage off, shower, soap and water, new bandage back on, and I want them to change their bandages daily. Some other expectations during that time period, it's probably going to be difficult to swallow certain foods. For some reason, patients mention French fries a lot as a difficult thing to you can munch it up, but swallowing it, they feel like it's caught in the throat. A lot of that's some of it could be from the intubation, from the anesthesiologist, not to blame them, but it also could be from pulling on the esophagus during surgery. The retraction there to get to the spinal cord is another thing that causes swelling and almost bruising, potentially, of your esophagus. And then neck pain. It sounds a little obvious. The ACDFs going through the front, they don't hurt nearly as bad as going from the back, so expect significant periods of neck pain during that point. In some states, some regions, some areas, home health agencies approved based on your insurance carrier. We usually order home health for all of our patients. So they come in, check on the patients, do very light physical therapy at that point. And then from my standpoint, I let patients drive usually whenever they feel up to it. Again, that varies from patient to patient. So please talk to your doctor on that. Okay, a neck brace is something I get asked about all the time. And again, this really varies surgeon to surgeon. So in general, the type of neck brace is like an aspen collar, looks something like this. Usually the surgeon has you wear it for maybe 2 weeks to 6 weeks. From my standpoint, I usually have my patients wear it all of the time. Of course, you can take it off in the shower. If someone needs a neck brace, this is a third-party website that I send my patients to order one of those. And definitely multiple studies show that on multi-level fusions, these neck braces help. I think from a pain control standpoint, it's been pretty helpful also. Okay, so now that we're 6 weeks out of surgery, what do we expect? At this point, thankfully, you can stop wearing your neck brace, and I would say like 90% of the patients are ecstatic by that, and that makes their day. At 6 weeks, I start outpatient physical therapy, going to the gym, increasing your weight limit. I want you to now lift up to 30, or you can now lift up to 30 pounds. And really, you should be expecting a pretty functional return to work, to most of the things you like to do. Again, depends on what your job is, right? If you're a police officer and you have to have active combat or tackle somebody, at 6 weeks, maybe you can't fully do that. But if you have a light duty work, if you can do more an administrative role, 6 weeks, you'd be expected to go back to many of those things. And then most spine surgeons are very happy to help with accommodations. Getting a little further out now, so at 3 months out, when I check on my patients again, now I would like them, if they want, they can lift up to 45 pounds, so really increasing the weight limit they can be bearing. And I usually tell my patients, look, I want you going to the gym. I know we stressed that before. And then still, at this point, seated exercises with a back support, seated with a back support is really helpful. It's just less stress going through the neck, less stress going through the spine. It's just a good way to work out, and I encourage that highly. Okay, so when we get 6 months out, now we're getting pretty far, right? Again, varies patient to patient, but usually at 6 months, I'm getting great radiographic evidence of healing, and we see that on x-rays. I take off most other restrictions for my patients, if not all of them. Again, this varies based on so many factors, but 6 months in general, I take off all restrictions. A question I get asked all the time is, can I go back to running? Look, I say yes at this point, and even before you can. But I mentioned, look, that's a lot of pounding, that's a lot of stress, not necessarily even to your neck, but to your lumbar spine. So I'm not at all telling people I'm a spine surgeon, don't run. But look, there's a genetic predisposition to why did your neck wear out and not your neighbor's. That could be happening to your lumbar spine. So just think about other ways to kind of stay active, stay fit. Cycling, rowing, swimming might be better for your lower spine than running. And then earlier we talked about nutrition. So this is something I've really worked on, really focused on. I think a lot of spine surgeons are. We think about, back in high school or college when you're getting ready for big athletic events and endeavors, you're really protein packed, carb loaded, worked out. I think we should think of cervical fusion surgeries that way also. In a way, you're undergoing a small trauma, and it's an elective trauma. You're picking to do it, where we're going through the muscle in the back or in the front, we're expanding the muscle, and then afterwards, you're really going to need to be healing that area. And so doing things like supplements with protein, carbohydrates, vitamins, collagen is really important. This QR code takes you to a website that I think is really helpful. It's a great way to kind of pre-op and post-op to really get that nutrition in, and the goal of really hopefully helping with fusion, helping with healing, and helping limit infection by just having the body be more strong. So we'll see. Okay, a couple closing thoughts here. Look, I tell patients all the time, there are so many fusions out there. Is it a 1 level? Is it a 4 level? Is it front? Is it back? Is it front and back? Is it going to the skull? Is it using facet fusion? Is it using non-instrumented fusion? There's just so many different ways out there. Standalone cages. Not every case is the same. And it's important not to judge what you've read online or what you've heard about one person's experience with what yours might be. So you're never wrong to talk to the spine surgeon. Just because they say you should do surgery doesn't mean you have to do it. It's always good just to know what your options are. I always stress technology. Technology is a big deal. We didn't have these type of fancy cages back even 10 years ago. This 3D printed technology has come a long way. Use of AI, use of technology is a really big deal that more and more spine surgeons are growing up with and we're using all the time. And I think setting expectations is key. We're not necessarily father time. We're not reversing the clock here. The goal of surgery is either to stop the progression of the spinal cord injury occurring. It is to take the pressure off the nerves so that it can hopefully start improving any wrist function, like weakness in the wrist, weakness in the shoulder, bicep, numbness and tingling you have. It's to stop the progression of that, hopefully reverse that also. So if you have terrible shooting pain, I tell my patients all the time, I highly anticipate that shooting pain will be completely gone after surgery. The numbness and tingling sometimes takes a while. Sometimes it's chronic nerve damage from months, years, decades of delaying the surgery that you needed. It's just hard to say. But that's a great thing that I always stress to my patients is, what's your goal? What are you hoping that we get out of today's visit and out of the surgery? And patient expectations is a critical part of spine surgery. So again, if you've made it this far, then I'm allowed to do a shameless plug. Look, telemedicine is something that we as a medical community weren't doing too much of back in 2018, 2019. COVID was terrible, but it kind of taught us that maybe telemedicine's nice. You don't have to drive all the way across town to see your doctor. And, if your family is working or you want to involve your kids in your healthcare process, you can get on a 3-4 way group call and talk to your doctor. You can go over the follow-up with your doctor. And that's a great way to seek help, seek ways to get better. From our standpoint, the way I usually do it is I have to have x-rays, straight on view, which is an AP view, side view, flexion, extension. I have to have an MRI. Interestingly, way too often patients tell me, my schedulers, hey, I have an MRI, why do you need x-rays? Well, because I said so. And then two, because your MRI, you're laying down and it doesn't show how gravity is impacting your bones. It doesn't show me the amount of bone spurs sometimes. X-rays are critical. Not having x-rays is wild. So you need to get your x-rays. Your doctor can burn it onto a disc or send it to you, and you get your MRI. And those are key things that you need to send over. In terms of how to get it to us, that's my address. And there's also a third-party app that I use called Mind Medical Images. That's a QR code that can kind of take you to them. I'm pretty sure it's a free account you can set up. It changes from time to time, so it depends on when you access this current video you're watching. But sending it over and then reaching out to our team to let them know you've done that is one way to do it. So look, I hope that this helps you for your upcoming surgery in terms of expectations. Surgery's scary. I'm sure as a spine surgeon, I'm definitely going to have one on my neck one day. Think about what we're doing all day. We're bending over. It's a lot of stress, a lot of bending, a lot of work on our neck. And, I don't want spine surgery myself. It's scary. There's always that less than 1% risk that you don't want to be. But I just promise you, your surgeon, speaking for them, is going to take great care of you. They care about you. They probably have kids in the same community that you are, and they want to have a good reputation, and they want to do what's right for you. So I just hope that you trust your surgeon, trust the care, and you're going to do great.